Right, we're ready to kick off the last session of the day. James Kingsland is going to be speaking to us. He's an excellent speaker. I've heard him speak lots of times, very thoughtful, knows what's really going on out there. He's going to talk about collaborating design, community-based services for long-term conditions. He's going to talk for about 20 minutes and we'll have about 5 minutes of questions so you can wrap up quite early if you've got to get away. Right, off to you, James.
Paul, thank you. I think I'm on. I don't even know anyone's heckling because they're all heckling all over the place already. So what I wanted to do is, at the end of the day, just put into context how it's all going to be managed in this bright new future. Did you feel the Earth tip on its axis on the 1st of April? It's completely reformed? Not yet. Just to give by way of background, I'm still half-time in general practice. I've been a GP for 25 years now. Anyone here from Liverpool or North West? Oh, of course. Hello. Well, I'm on the Riviera side of the Mersey in Wallasey. The other half-time has been contracted to the Department of Health for the last 4 years to try and get clinical commissioning some momentum behind it, or a consistency in narrative about how it will work, why we've got primary legislation, and why we are linking the accountability of clinical decision-making with the fiscal consequences. So to put into context, what I thought I'd do is from a GP's viewpoint, just to give balance, I'm a non-exec of an FT as well, but it is going to be about why we need, and why it was first called GP commissioning, the primary care system, particularly general practice and list-based practice, to step up to the plate, to improve its capacity and capabilities, and I know my colleagues are going to start throwing things at the moment. I'll describe how that may be done, to deliver what was first coined in the white paper of 2006, which Norman Warner delivered, about out-of-hospital care. Because long-term condition management, I don't know where that term came from. As a clinician, I still talk about the management of chronic disease, management being diagnosis and treatment, and chronic disease, we're mainly talking about the 5 big killers, because long-term conditions covers everything from cataracts to HIV, endometriosis to MS. But if we're talking about cardiovascular disease, the biggest killers in stroke and heart disease, COPD, CKD, diabetes, and some cancers, that is where the focus of efforts of the primary care system, particularly general practice, in extending the care to make more and buy less from another service. And particularly the repatriation, I don't know, I've got infected with DH terminology, but the movement of patients' routine management from the outpatient department back into general practice. Now at this point, a lot of my GP colleagues say, OK, Kingsland, talk me through the headroom in general practice when we are a full service. Talk about how we're going to resource it. What about my estate, the workforce? Well, that is all part of the redesign and the reason why we've got primary legislation to reform the care system. And if we can reform the care of long-term condition management, urgent care, which I'll be talking about tomorrow, same principle, and we sort out health inequalities, we're more or less done. But to focus on the massive activity, because some of my colleagues say, well, we've done outpatients and chronic disease management to death. All the evidence is we haven't even started on it. I've just been doing some work with UCLH, the 5 hospitals of University College. They have about 800,000 outpatient contacts for new patient and follow-ups per year. Their discharge rate, and they've been critically appraising the need and the ability to discharge patients. Their discharge rate, when they started looking at it, and this was about average across a range of hospitals they were collaborating with, less than 10%. So less than 10% of that activity, and that is consistent across all hospital services, and a lot of that outpatient activity, as well as the new patient, is the routine monitoring of long-term conditions. They've done some dedicated work, started to talk to their primary care systems where they've got more confidence about the early discharge, and have moved it up to 15%. But we've got to move it to a significant proportion so that we're getting consultants to consult, and the majority of that, what is safely moved into the primary care sector, to the primary care home, with a movement of the workforce and some of the resources to do it, is the programme. So I'm not going to talk about specific care or how to do it, but the process has got to be a collaborative approach whereby there is a confidence and a dialogue between the primary care sector about the systematic approach to removal of the monitoring and the reviews of patients with a whole range of long-term conditions back into general practice. Now, for the commissioning programme, about how it's going to be done, we've always known that if we are going to move care between sectors, been talked about for 20 years, so the White Paper 2006 first talked about out-of-hospital care, if we're going to do it, there has got to be a resource shift. And most of the innovative programmes I've seen over the years, practice-based commissioning, has always done something that changes a care pathway with a notional release of resource at the end, never an actual, because it doesn't challenge the very core of what we need to do if we're going to release enough resources to get the estate right in primary care. That's a big issue. Get to the workforce right, the skill mix, so that the capacity to move that caseload. And the resources, if we're going to talk about new care pathways, where there's better diagnostics, where patients access the NHS, i.e. through their registration, if there is earlier diagnosis and then ongoing management, using the wise counsel of our consultant colleagues to help with that management, but most of it carried in primary care, we can't do it with the current arrangements in general practice. There's got to be a resource shift. And we've always known that probably with the quality and productivity challenge, old hat now, the idea of just releasing £20 billion to meet the challenge is long gone. It's at least 4 to 5% a year forevermore, just to meet all of the well-rehearsed changes that we know with the demographic change and the new strains on the NHS. But to deliver against that, commissioners at the start of a programme of redesigning, I was talking earlier about a redesign of musculoskeletal services at a different conference, the commissioners have got to be clear about that if we are going to release resource by an innovative redesign of care, it might meet 25-30% of the challenge. The rest of the resource is always going to be released by workforce redesign, and it wasn't necessarily going to be by losing 40% of NHS managers from PCTs or pay restraints, although that has been part of the programme for the quality and productivity challenge. It was redeploying human resource for right care and certainly sourcing a different skill mix in the primary care system where patients access the NHS. The second is the tariff redesign, because if we've got a new care pathway, if the tariff doesn't evolve to reflect that, we've seen it with best practice tariffs, but the tariff, the HRG4, started to do it by having better incentives for day case surgery rather than inpatient care. But the tariff design has got to start to shift billions around the system with these new care designs. But finally, if commissioners do not want to have the discussion about if we are then moving a lot of care between sectors, the biggest resource release has always been from estates. And whilst we do not want to destabilise any sector, and we've still got to invest in the vital services, which is the second, we call it secondary care, we've got to get rid of these artificial terms, that if we don't look at the redesign of care that says as a result of outpatient departments moving a lot of long-term condition management into primary care, we've got to close the outpatient department, switch off the lights, redeploy the staff and close the building. Now, I'm oversimplifying, but if we don't have that discussion at the start of the commissioning programme, we will always have a fantastic care pathway, a notional release of resource, and then a fight at the end about where that resource is going to actually be invested in a new sector. And we'll have the first person chained to the railing of the hospital that might be having part of its estate closed as the local MP, followed by the GP commissioner and some of the patients. So we've heard about the tough talk and tough decisions, but if we're going to be clear about the change of care pathways for patients with long-term conditions, the huge element, I mean, long-term condition, it covers most things that certainly the health service deals with, and the biggest killer in terms of its global effects that we're going to have to deal with. If we're going to be serious about it, all of those issues have to be addressed in the commissioning process. And if we'd have called it, rather than clinical commissioning, and this is what I wanted to call it, but it didn't quite get through, at least we changed it from GP commission. If we'd have called it the reform of primary care provision, I think most of it in primary care would have got that. Because if CCGs do nothing more in the first year than look at the quality, the capability and the capacity of their members, interesting concept, isn't it? GPs practice as members of a CCG. Have you ever been a member of something you had no choice about? Anyway, but the members of the CCG have got to recognise that this is not about buying differently. This is about making more in the primary care sector and buying less as a result of innovative commissioning of long-term conditions. And we've got urgent care, which you'll hear tomorrow morning about. But if we don't address it at the point at which we say, well, for the new care pathway, which is earlier diagnosis, earlier intervention and management out of hospital, the consequences to the tariff reform, the workforce and the estate has got to be addressed in that commissioning programme. Otherwise, we will have fantastic ideas, different ways of managing, importing new technology, but still finishing with, and my concern is I'm seeing too many CCGs still block contracting in this year one with the hospitals for understandable risk management. But again, that type of contracting will still not release the resource to beef up the primary care system. And my concern is if we don't, and this is not just the GP talking from a protectionist position, NHS, I'm absolutely clear, is free at the point of access, not based on anybody's ability to pay, because we register for service with a primary care system. That registration, patients have got to expect far more from that registration, and where they register have got to be far more ambitious from a delivery of care which includes a skill mix of the traditional general practice we know of GP, practice nurse and administrative team, but the whole range of health, social care, community and third sector services, which I see in, 20, 30% of practices around of England. And as I travel around, the reason why I can stand on stages and say it will work is I'm inspired by some fabulous general practice that are developing what we've been calling the primary care home approach, where you register for a range of coordinated services, including your long-term condition management, your diagnostics, your follow-up, and a better link with secondary care for the expertise of the consultant team to advise on that management programme. But I say I'm inspired by the number of practices that are almost there and doing it. I think it is achievable, but it ain't going to be done by just the marginal changes to certain aspects of chronic disease management. It's going to be by the whole system approach that releases resource to invest in a system that, if it's right, and we do keep list-based practice as the cornerstone of the NHS, we will maintain, even after the next election, an NHS free at the point of need. If not, there'll be a different discussion. And Chairman, on that happy note, I'll take a breather, but I wanted to put it into context. I know it was a brief run round. I've got some more about details of how it might work if need be, but I'm happy to take some questions at that point.
I think questions would be great, actually.
Especially challenges to that concept. If it's all agreed, if it's silent and we're going to do it, and Gina would always ask the first question.
That's right. Gina, do you want a microphone or can you manage? I think you need a microphone. Hang on there. That's better.
Hello. So both you and Claire Gerarda have talked up delivery in primary care. Absolutely with you there. I'm a GP, by the way, so self-interest. But increasingly, stuff that's coming out of hospital, for example, the follow-up of the PSA test post-treatment for cancer, the commissioners feel they have to go out to procure because of conflict of interest. So what I'm hearing is a list-based, I love that. The home hub, love that, so you might have lots of providers in. But if you start fragmenting, which was something that Claire Gerarda warned us against, primary care, then you're back to managing lots of little contracts who don't feed into your list. So how do you round that square?
If it is about the conflict of interest of extending patient care and paying, I'm not saying you have to pay the practice to do it, you've just got to resource it with the right skill mix to release some time for the generalist to have the estate and the diagnostics right. But on that sort of I'm trying to think of it, bringing back care into general practice, which is within the generalist remit or the generalist team, it's safe to do so and is acceptable. And sometimes we've always struggled to define exactly what the generalist team does in primary care and at what point is the boundary. I've spoken to all the defence unions with the Department of Health about this. At what point does a procedure become acceptable for primary care? You know what the answer is? When would we get indemnified against doing that procedure? When about 20% of practices are doing it, is the best they've come up with. So when it becomes done on a regular basis and it's acceptable, then our indemnity will cover it. But the idea of bringing back patients for the lower tech, low complex, generalist type care and saying, well, no, if it was done in secondary care before and there was a resource going for it, to bring it back and go out to tender is silly. It is an unnecessary process where we're getting wrapped up in procurement as something that is obstructive to expanding. Whether we like it or not, we've got a system, whether it should, of the choice of primary care service or general practice services ends when you register. You can't register with more than one practice. Well, some students do. But the idea is that your choice for primary care service, you have the choice of primary care service, you should then expect that extended range of services. And if the generalist team, and it is safe to do so, says we can deliver the monitoring of that PSA, but where the resource used to go now needs to be redeployed within the primary care sector, not necessarily to pay us to do it. It's about we might need more district nursing to support part of the programme of long-term condition management, and the resource that used to go unnecessarily for a service we can now safely provide is now in the primary care sector to be redeployed differently, which is different to saying, well, we're going to set up a new provider service to do what the hospital did instead of them and get paid for it. That is out to competition. But if you're saying I'm just bringing it back into the generalist care of the organisation where patients are registered, that is not contestable. Other than that, registration is contestable. And whether list-based practice survives forever, who knows? But I mean, as an advocate of it, that is the system we've got, so that would not be a conflict. Challenge me, somebody, on that. Sorry, Scott. Sorry, Chairman, I'm taking you.
Right. No, it's okay. There's that lady there with waving the hand with the microphone.
Yeah. I absolutely agree with your concept, but how do we get around practices who say, with that repatriation, that's not core GMS?
There's this debate about core GMS. Looking after patients with COPD who have been frequent attenders or frequent admissions and to get them back from outpatients, and that's not core GMS? Following up patients with MS is not core GMS? Early diagnosis of chest pain and then, extending the care to a point at which you just need a consultant to consult is not... Yeah.
I agree with you, but actually some of our GP colleagues do say, but that activity has been going on in the acute sector. To repatriate it is a whole new volume of activity, and what our practices are also reporting is that demand for their services is unprecedented. They literally are struggling to cope with the sheer numbers of patients coming through the door. So that's where we sort of struggle to engage.
Now, that's where the debate about the primary care home and where the resource used to go doesn't pay them to do the work. It's saying we're now deploying it differently. So why are you overloaded? We've got to critically appraise what the generalist does, and we've got to be very careful about those who say, well, 50% of what GPs do could be done by a nurse, because then the nurse gets upset, and 50% of what nurses could be done by a healthcare assistant. But we have got to analyse the type of work. I'm still in general practice half-time at, say, 25 years. There is still a significant amount of presentations into my surgery, and we have got third sector and social care and diagnostics in our practice, still would be better delivered by a different healthcare professional. And we're starting to try and empower our patients that if they've got a situational disturbance, a relationship breakup, then their first port of call might be the counsellor. If they've had a road traffic accident and a whiplash injury, the first port of call might be the physiotherapist, but they're on site and immediately responsive. That needs resourcing, not out of my income. So we bring that in. That allows me to have more time from those patients who used to see me to bring back those patients for long-term condition management. We've got to rethink, and that's why I was saying about the reform of primary care provision. If we say I'm full as a clinician generalist with whatever comes through the door, yes, it's impossible to change. If it's a rethinking the need of that population, I was hearing earlier about a more strategic view to population health management for the registered population and the role of the generalist, clinician, physician within a bigger team. A lot of what general practitioners do now could be delivered by other health or social care professionals to allow them to take on a different type of workload. It's a big concept, but that can only be done if we've got the community nursing team and the ability to buy in some third sector work, because the frail elderly, the patient I saw this week who is perceived to be depressed because of their loss, their bereavements, their grief and their social isolation, have been better dealt with by Age UK, who's on our site, than my consultation. Okay, I saw them, but they're now being socially integrated and treated by another part of what we see as the primary care team. That's freed up a bit more of my time. Now, I know I'm giving just sound bites here, but it is about reforming the primary care home for 21st century general practice, which some have done already. But if we're saying it's impossible with full, I don't want to talk about the alternative. Sorry.
Just chat.
It's going to be a good.
It's coming.
No, I'm not going to give you a really hard time. And I'm following on from what was said before, because I think this is a really important point. And my guess is that everybody in this room would have a similar example to the lady at the back. I'm paraphrasing here, but I want to get this really straight. So when we are faced with this dilemma, we are spending a lot with activity going in secondary care that could plausibly be done in primary care because we have the knowledge and we don't need fancy equipment to be able to do it. And sorry if this causes offence, but to the LMC sorts who say, this ain't core primary work, I want paying for this. Our answer to them must be that this is expected. This will save the CCG money, and in return, we will then, as providers, ask for the CCG not to be paid for that new service, because then we get the problem of tendering and conflict of interest, but we will say to the CCG, I am taking on this extra work, it is saving you money because you're not paying secondary care tariffs, and therefore, I would like you to use some of that money that you're saving to pay somebody else to do work that I would otherwise do that they could do better. So your examples of the physiotherapist, the counsellor, etc. Is that the way you see the arguments working?
Exactly.
Okay.
That is the process by which you've saved a resource going into one sector, you're redeploying it, not to necessarily pay the general practitioner, but to take on some of the workload. Now that investment, because we're talking about where do we get investment in the States, in diagnostics on site, new healthcare personnel, different skill mixes, that is used. It might be that the general practice says, well, we've got a big workload because we haven't got enough district nurses. Well, use it from PSA to buy more district nurses.
So my question to you is that it is very important for us to think what can we do that secondary care are now doing, but equally important to think what are we now doing that somebody else can do just as well as us at a cheaper rate, basically.
Yes.
Yeah, thank you.
Exactly.
I certainly agree with your last point there. You mentioned GP estates, primary care estates. I have a vested interest, but is NHS England actually funding any new development of GP estates? Don't
know as yet, but they are at present, with all the shift of the estate resource of PCTs into the new PropCo company, and the ability to start to see whether CCGs will have some resource to invest in estates is still, unless somebody else knows where we're at with that. But there's no question that the estate issue of primary care has got to be addressed.
Why do CCGs fund a primary care building? Should it not be an NHS England issue?
Well, whether it's the area team, I haven't got the answer to that. But there's the bottom line is, if we don't look at estate development in the community, because we've got some fabulous GPs working in very disorganised arrangements, who again say, well, I could do, but look, I need some sort of support to either federate, amalgamate, redesign my estate. And if we don't address that, the idea of one doing it on a shoestring or bringing back the work into some of the estates that are fabulous, but others are, we use them, not fit for purpose. If we don't invest in that, it's going to be impossible to bring that work back.
Thank you.
Just Chap here.
I'm just picking up what the gentleman said at the front. I still don't quite get it, because at the end of the day, as a practice manager, the most logical thing is these people sort of work in my practice, and an extra nurse who's going to help manage the long-term condition, a relatively big practice. It'd be great to be able to afford an extra nurse to be able to support that. And the money has to follow, and it has to follow logically into my practice to pay that person. And the only way of doing that is through the contracting mechanisms with the GP practice. But you're saying, no, we're not going to give more money to the GP practice. Somebody else has to employ this nurse. And then how does that work? And then you've got another agency employing the nurse. I mean, the simple thing is the money has to come into the practice to employ these people. And you've skirted around that one, I think.
What I was saying is that it is not just about paying the GP to do more work. If the resource is needed to increase the practice employed staff, fine. But if the resource is better used to say, well, we could use it differently in social care or third sector to support the practice and put it in practice, or they need more on-site diagnostics or indeed an estate, there's a whole range of ways of doing it. It's not saying it can only be done that way. There's no reason why a practice, and my own practice, has been successful in saying we'll demonstrate a process by which we're doing some work. I'm talking about an urgent care, but we need to resource in the early stages more clinical time to have a practice that's never full. We'll demonstrate a process by which no one is ever turned away or told they've got to wait for an appointment at surgery. But we've got to measure the right clinical skill mix per 1,000 population to do that. We need some investment to do it.
So some of it will be new money coming into practices. That's what you're saying.
There's no reason why it shouldn't be.
Okay.
On that note, I think we'll wind up. But absolutely brilliant, James. Thanks very much indeed. And thanks for your questions, which I've no doubt we could expand those, and perhaps you'll get collared afterwards, I've no doubt. Anyway, thank you all for coming. Thank you for a successful first day. Thank you very much.